Yeah. Good morning, everyone. I am Dr. Ankit Jain. I am an associate professor of cardiology in Safdarjung Hospital in New Delhi. I will be presenting a case of pulmonary sinus re-entry VT in patient with structurally normal heart. So he is a 40-year-old male with history of recurrent palpitation and history of pre-syncope since last 6 months. Once he required DC cardioversion for termination of his tachycardia. He was having normal biventricular function and normal valves on echocardiography, and no evidence of any structural heart disease in cardiac MRI, and no evidence of late gadolinium enhancement anywhere in the. So his baseline ECG was normal sinus rhythm with normal axis and narrow QRS with no special character. So this VT of LPPP morphology, inferior axis and V4 transition was repeatedly induced by RVS1S2 pacing. So after right ventricular angiography to define the level of the pulmonary valve and RV function, we started mapping with the ablation catheter. We found activation 58 milliseconds prior to the QRS, just below the level of the anterior pulmonary cusp in the high RBOT. Bipolar signals there were in opposing direction, suggesting we are at the level of the exit side of the BT, and unipolar signals were slurred QS pattern. We started ablating there, and after 40 seconds of ablation, the VT got terminated just at the same site. This was the catheter location during termination of the VT in the RAO and LAO projection, just below the level of the anterior pulmonary cusp. So after the ablation, we started re-inducing VT, and we induced another VT by RP extra stimulus pacing. This time, the tachycardia cycle length was the same, but the QRS the morphology of the VT changed. The transition was at the level of the V4, but the lead 1 become more positive, and lead 3 become less positive, and lead AVL become positive, suggesting that the exit site is now changed down in the right ventricle and also more on the right side. The another thing that we noticed that there is slight variation in the QRS morphology, best appreciated in the lead 3 and lead V5 and lead V6 with the same tachycardia cycle in, suggesting that the exit site is changing in the right ventricle because of the preferential conduction from the source of origin. So as these features are common in patients who are having arrhythmia origin in the pulmonary artery cusp because of the multiple pulmonary sleeps, we started mapping the pulmonary cusp. So for mapping the pulmonary sinuses, we make a U curve in the ablation catheter with the help of the SL1 sheath to reach the depth of the pulmonary sinuses and for the better contact. So we mapped the 3 pulmonary sinuses, and in the left pulmonary sinus, we found late to late diastolic to mid diastolic signals at the tip of the ablation catheter recording. We started doing entrainment, and we found that entrainment was concealed at that site, and stimulus to QRS and the EGM to QRS was same, and the PPI to TCL was 0, suggesting that we are at the exit site of the VT isthmus, and we started doing ablation at this site, assuming it to be in the circuit. Before doing ablation, we did the coronary angiography as we were ablating in the left pulmonary sinus that is closest to the left main pulmonary artery in the RBOT. So we did the pulmonary angiogram, and after ensuring a safe distance from the left main coronary artery, we did the ablation, and the VT got terminated after 30 seconds of ablation. As it was a re-entrant VT, to completely transect the VT isthmus, we did the ablation in the entire length of the left pulmonary cusp. After this ablation, we started inducing VT again, but the VT was non-inducible anymore. The possible substrate of this VT may be related to the normal arrangement of the pulmonary valve junction. In normal, pulmonary cusps are arranged in a semilunar fashion. So, the anatomical ventricular arterial junction is above the level of the uh, attachment of the proximal attachment of the cusp, pulmonary cusp. So this creates a uh, triangle of fibrosis of pulmonary artery musculature interposed between the normal myocardium and the fibrosis of the pulmonary artery. So this is possible. This possibly create a delayed conduction inside the pulmonary artery and slow conduction required for the formation of the VT stenosis. And because of this cellular attachment, some normal myocardium is interspersed with the fibrous tissue. This normal myocardium can only be reached by the formation of the reverse U-curve ablation catheter because it is in the depth of the sinuses. If we try to ablate this by the normal curve, we cannot make contact because of the pulmonary wall coming in between the myocardium and the ablation catheter. So to make a contact and ablating these and mapping these VT, reverse U-curve is very important. So take home message from my case is that surface ECG is suggestive of exit site of the VT and the origin of arrhythmia may be removed. And pleomorphic QRS morphology may be seen from the VT or if the VT origin in the pulmonary artery for the multiple preferential conduction sleeves or if it is deep intramural foci, then that can also lead to pulmonary different QRS morphology during VT. And if we ablate one exit site of the VT, the second QRS morphology may be manifested. So, and this case also showed that re-entry may also be seen in patient with no apparent structural heart disease. And mapping by reverse U-curve ablation catheter improve contact and chances of success when ablating VT inside the pulmonary sinuses. Thank you. Thank you.
Good morning, everyone. I'm Dr. Abhinav Anand. I'm currently doing fellowship in electrophysiology in Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bengaluru. Here, I'll be presenting an interesting case of iodoparin-sensitive atrial tachycardia. My patient was a 70-year-old female. She had history of gradually onset progressive dyspnea since the past 6 months, which increased since the last 1 week and was associated with orthopnea. When she presented to us, she was NYG class 3 with marked limitation of her physical activity. She did not have history of syncope, chest pain, or any other significant past history. On general examination, JPP was elevated. Auscultation revealed presence of S3 and bilacial crepitations. ECG showed presence of regular narrow complex tachycardia, a heart rate of 150 beats per minute, with long RP, with 1:1 EV conduction, with negative PVA in the inferior left. In view of the above finding, we kept a differential of or typically AV and not B, atrial tachycardia, and PCRT, although less likely, as a differential diagnosis. The patient was given 12 mg IV bolus adenosine, which led to termination of tachycardia. This was followed by reinitiation. The tachycardia showed combination with QRS complex, which supported a differential diagnosis of atrial tachycardia or typical AVNRT and PGRT, but did not narrow it down further. On further analysis of the termination, we should notice a slight pause in cycle length before termination. The change in AA cycle length preceded and was driving the change in VV cycle length, thus making a diagnosis of atrial tachycardia. On analysis of P wave morphology and ECG, P wave was negative in V1, suggesting a right atrial origin. It was not positive in V2 to V4, suggesting a non-cresta origin, and negative in inferior lobes, suggesting a tricuspid annulus origin. In view of incessant tachycardia with a likely diagnosis of atrial tachycardia, we loaded the patient with ivabradine 10 mg single dose according to our institutional protocol in incessant focal atrial tachycardia, which I'll discuss subsequently. This led to termination of tachycardia within 2.5 hours of ivabradine administration. The patient was subsequently started on decongestive therapy and was started on oral ivabradine 5 mg twice daily. Her echo revealed presence of reduced LVEF with an ejection fraction of 36% with global hypokinesia. Patient underwent MRI, which showed presence of global hypokinesia with reduced LVEF. There was no late gadolinium enhancement. After stabilization, patient was offered electrophysiology study and radiofrequency ablation as a curative therapy in view of symptomatic dyspnea and tachycardiomyopathy, which they agreed upon. This is in accordance with ESC guidelines on SVT, which recommends class 1B for recurrent focal AT, especially if incessant or causing tachycardiomyopathy. Patient was taken for EEG study after taking informed consent. Ivabradine was stopped for 2 days prior to the procedure. On table, patient was in tachycardia with a tachycardia cycle length of 340 milliseconds with 1:1 AV conduction with earliest in CS 910, the onset of which coincided with the onset of the P wave. The CS catheter was then sutured in and CS 910 onset was taken as a surrogate marker for the onset of P wave for mapping purposes. After confirmation of stable 1:1 VA conduction during tachycardia, RV overtime pacing was performed, which showed a VAAP response. Pacing from CS12 showed a return cycle length of 510 milliseconds, which was considerably longer than the tachycardia cycle length of 340 milliseconds. Differential site atrial pacing showed a VA of 180 and 140 milliseconds from CS12 and 910 respectively, with a delta VA of 40 milliseconds, which was more than 40 milliseconds, suggestive of atrial tachycardia. Using ablation catheter as the mapping catheter, mapping of RA was done. RA geometry was created, which showed earliest activation at tricuspid annulus 7 o'clock position, which was 34 milliseconds earlier than CS 910, and hence the surface P wave. The activation map showed earliest activation at infralateral tricuspid annulus at 7 o'clock position. The propagation map showed centrifugal activation with earliest activation at infralateral tricuspid annulus. In view of the above findings, a diagnosis of focal atrial tachycardia was made. Ablation of the Yes, side led to the combination of tachycardia within 2.7 seconds. At 3 months follow-up, the patient was asymptomatic with normalization of LVEF. Ivabradine, which inhibits the IF current, has traditionally been used for chronic heart failure or controlling the heart rate in patients with recurrent hospitalization and as second-line therapy in chronic stable angina. However, there have been case reports of use in postural orthostatic tachycardia, junctional tachycardia, and atrial tachycardia as well. Ivabradine selectively inhibits the funny current IF, which are mediated by the HCN channel, resulting in a decrease in rate of vascular depolarization. Ivabradine blocks the channel in its open state, creating a particularly favorable attribute, that is use dependence. That is, it becomes more potent at faster heart rate, which makes it particularly useful in tachyarrhythmia. The physiological basis for the use of ivabradine comes from this autopsy study, which showed presence of HCN4 channel in widespread areas of right atrium, although they are predominant in the SE node. Notably, in this study, they had taken sections only from right atria and did not examine the HCN4 expression in the left atria. Response to ivabradine also provides mechanistic insights into the pathophysiology of tachycardia. Successful responses to ivabradine indicate involvement of HCN channels in the pathogenesis of ISAD and may be considered as a marker of automaticity as the underlying mechanism. The first clinical case report for the use of ivabradine was from India by Bora sir and Yash Lokhandwala sir, wherein the patient showed normalization of LV function within 1 month of starting ivabradine. Finally, I would like to discuss our institutional protocol. According to our experience, which was published in circulation, a trial of ivabradine should be considered in all patients with incessant fat, which is focal atrial tachycardia and structurally normal heart. In responders, ivabradine may be continued as a bridge to ablation or destination therapy. Catheter ablation being potentially curative should be offered to all patients. Thank you.
Thank you very much for having a very, very rapid presentation within time limits. I think beautiful presentations. Congratulations to all three. What I intend to do is to go back to the first speaker and have some questions about his presentation. Is that okay? So let's go back to the unusual site for overdrive pacing, which is very interesting, that you put a catheter in the coronary sinus. And by pacing that, you suppress the arrhythmia. Let me go first back. My first question is, can you describe the width of the non-sustained VTs you have and the morphology? Where do you think the site of origin might be?
So they were multifocal. They were arising from multiple foci.
Yeah, but you showed on the ECG two doublets and ECG further, even triplets of quite 4 beats of a non-sustained VT. And if you look to the morphology, what strikes the eye is that the width of the QRS complex is very narrow in comparison to the dilated, the widened QRS complex in sinus rhythm. Do you have any suggestion why this QRS complex and the ventricular complexes you see is so narrow?
So probably arising close to the septum
Yeah. And if you look at the morphology, it's positive in leads 2, 3, an AVF, and more or less isoelectric in 1. So that means that it's coming from high up, and it's more narrow than the QRS complex during sinus rhythm. So you think indeed that it might be coming from high up. Do you think there is an additional rule maybe for the conduction system to have this narrow QRS complex, or you think it's not valid here?
So I don't think it is valid because there were multiple runs, and also this was the one which was documented, but on the cardioscope we did have multiple morphologies which were seen.
Okay. Do you agree with my argument that the conduction system is not very healthy anymore if you look to the sinus rhythm? So I support your idea that the conduction system is not a cause that this QRS complex is so narrow. You have put the catheter in the coronary sinus. Can you give me an idea where, if you enter the coronary sinus os, how the anatomy of the coronary sinus is going along the AV groove and where it passes to the ventricle?
So it's going posterior to the left atrium. So it's going along the border of along the border of the AV groove.
Yeah. Unfortunately, you said pacing from there could suppress the arrhythmia, but I didn't see a recording of the site where you did the pacing, so I couldn't see an atrial or ventricular recording. Can you comment on that? How was the difference in atrium and ventricular size at the site where you paced? Did you really capture the atrium? So did you have an atrial deflection on the pacing catheter? Because it was an ablation catheter I saw. Huh?
Yes, sir. So we actually on the ECG on the EP system we could not actually I didn't document that, but we did have significant atrial capture, sir.
Okay. If you see that the coronary sinus os is at the right atrial level, and then it passes indeed in the left atrium in the posterior wall, at the level of the two marginal branches, it passes to the ventricle. So if you put it more anterior, you end up in the ventricular side. And did you pace also the ventricular side to see whether that suppresses the arrhythmias?
No, sir, we did not try that.
Okay. Your suggestion was that maybe dengue caused the irritability of the ventricle, causing the arrhythmia. I have two questions concerning that. Is that you think that the irregularity due to the ventricular premature beats has worsened the left ventricular function in this patient, or was the left ventricular function of this patient already not very good at the beginning?
See, at the beginning also it was compromised, but I do feel there was the component of myocarditis also with the PPC burden and the arrhythmias. So the LV function was compromised even more in combination with the myocarditis that we were suspecting and the arrhythmias. Although there was improvement after the arrhythmias subsided, improvement of the LV systolic function. So I would like to say that the LV systolic dysfunction was owing more to the arrhythmia burden rather than the myocarditis.
Yeah. If you suggest that it may be a kind of myocarditis due to the dengue, what are the arguments further? Because if I remember correctly, you showed the troponin levels not to be elevated at that point in time when the patient had his ventricular premature beats.
Sorry, sir, I didn't get your question.
Well, if you think it's myocarditis, very often you see changes in troponin levels, that they are elevated. And if I remember correctly, the slide you showed the troponin levels, which were within normal limits. Is that correct?
Yes, sir. So, but troponin levels, we did not monitor them serially, but also they can be fallacious with the raised creatinine, also with an inflammatory state like that. So probably that wouldn't have given us a better idea of whether the degree of myocarditis really was substantial enough.
Okay. Do you have any impression that even if the cardiac enzymes are normal, that still the dengue can cause the arrhythmias?
Possibly, sir.
Yeah. One question which is of scientific interest is, did you also stop the atrial pacing with the implanted pacemaker to see whether the ventricular ectopics came back?
Yes, sir, we did. When we were trying to reduce the atrial rate, now the atrial rate was set at 100, and when we reduce the atrial rate further, the PVC burden would increase. So now, over a 1 month follow-up, he's maintained at an atrial rate of 100, and we further want to decrease the atrial rate further down so that we see the suppression of arrhythmias, even though we have a low atrial rate.
But this also supports your suggestion that it may be caused by dengue, that say if after 2 or 3 months of pacing, you would stop pacing completely, that it doesn't come back, the ventricular ectopics?
We hope it would completely resolve. The myocarditis would completely resolve, and if there is any post myocarditis inflammation there, that would resolve the arrhythmias.
Okay. Thank you very much for answering this very difficult questions, but it's a very nice and interesting case you presented. I don't know whether Dr. Naik has additional questions to...
Just a comment that we've done this fairly often in certain patients, and instead of putting a quadripolar catheter in the CS, we put generally a decapolar from the jugular vein, so it keeps the patient slightly more mobile. You can stabilize the catheter using deca, but pace more proximally in the CS horse region. Somehow the hemodynamics may be a little better. And if I need to use femoral, then I would use a balloon-tipped pacing catheter also in the appendage that stabilizes things better. These are just different ways of doing it. That's all. But nice case. Thank you.
Thank you very much for the additional comments, and thank you very much, Dr. Shah, for the case.
Thank you.
I want now to proceed to the second case by Dr. Ankit Jain, which was the pulmonary cusp reentry case. Again, a very nice and interesting case, very complicated also. I have some questions. Could you describe, please, for me the ECG and sinus rhythm of this patient? Let me have a look at your slides. I think it was the third slide in your presentation, because it's, well, describe it please for me, because it's interesting, I think. Maybe you can unmute your microphone, then we can understand what you're saying.
Yes.
Okay.
Yes. Good morning, sir. The ECG is a narrow QRS and around B5, B6 transition. And there was a ST elevation in the lead AVR that I could not explain, but it was recorded in the EP system. The normal recorded ECG I don't have, but it was the ST elevation in AVR was not there in that ECG. This was from the conventional 2D recording system.
Yeah. One of the questions I have regarding the sinus rhythm ECG is that the R wave progression in the precordials is very, very late. I think there is also even in V6 there is not yet an R wave. So is that due to the patient itself? Do you have an explanation for this? Because it should be a patient which has a normal body weight.
Yeah, patient was having normal body weight, but slight scoliosis was there in the patient, and this ECG is from the EP system, not from the normal conventionally recorded ECG. So maybe some electrode misplacement maybe also be there.
Okay, so the electrode position might be here the case. Then you have a beautiful ECG of the left bottom branch block VT.
Yeah.
Where do you think the transition in the precordials is that of importance for localizing the VT in this case?
Yes, the precordial transition is at V4 level, and it is prior to the sinus transition. So this VT can be from the left side also. So
Okay. Yeah. If you look to your earliest registration of the local potential and the pulmonary under the pulmonary cusp, you showed now the timing, which I couldn't see quite clearly. You thought that the timing was 50 milliseconds before the onset of the QRS complex?
yes, sir. Yes, sir.
And so you gave at that site, you gave RF energy?
Yes.
And it terminated.
This is below the level of the pulmonary valve, below the anterior pulmonary cusp. In the high RBOT, we give ablation there, and the VT got terminated first.
Yeah, and what are the criteria which we were using very frequently? If it's more than 40 or equal to 40 preceding the onset of the surface ECG, you're probably at the right site. So you gave energy and it stopped. Were you not tempted to give sometimes more energy? Because one of the reasons that it might terminate and it can be reinitiated is that the site of origin is a little bit deeper in the myocardium.
Yes, sir. Yes, that the signals were also the bipolar signal were opposing polarity, and the QS was slurred. So we were thinking that the origin might be deeper in the myocardium because of the slurred QS pattern. But we give full ablation there first. After termination, also we continue energy for 1 more minute. But after completion of the lesion, we started reinducting the VT again, and it was a different VT that got induced.
Yeah, that's beautifully shown on the ECT. Do you think that making several ablations under the valve might create a side of conduction block, which suggests that the re-entry is there present? You might think that might be a problem. So if you give multiple RF applications under the valve, then you make a little scar actually.
So you are thinking that the second VT might be iatrogenic, or what you are suggesting? I'm not getting.
I'm not suggesting, but I'm asking you a difficult question, because if you apply several times energy, you might create a little barrier there, which the conduction goes around. So do you think that this might suggest that it's re-entry, or do you think this is not a problem because it's really above the valve?
I think you cannot reach that myocardium from the below the valve. So the VT circuit remain unaffected by our ablation below the valve. And the second VT exit changed very much down in the RV after the ablation. So it cannot be the same VT that is just changed that is just created because of our ablation.
But now you think it's one VT with different exit points?
Yes.
Or you think the second morphology you saw was a little bit different a different VT?
Yes. I think we have ablated the first exit during the first ablation, and then it changed the exit and the second VT, and the circuit remained the same.
Okay. One of the major issues in successfully ablating an arrhythmia is the contact of the catheter with the tissue.
Yes.
And I think you beautifully emphasized that using a support catheter and making the U curve, that then the catheter has very good contact. One of the ways that you showed that you suggest it might be re-entry is the fact that you have this mid-diastolic potential.
Yes.
Could you give me an idea how much time that is preceding the surface ECG during the VT?
The mid diastolic, sir, was proceeding around 74 millisecond before the onset of the QRS during the VT. So it was around 30% of the tachycardia cycle length.
Okay.
So suggesting it is near the exit site of the VT.
I think you showed a beautiful case. I think there are up until now a couple of cases described, 3 if I remember correctly. So this is really a very nice case, and I congratulate you with this presentation.
Thank you, sir. Thank you.
Maybe Dr. Naik has some additional comments? Or
no, I think this was an excellent discussion. Everything very nice, good case. Did you map in the left ventricular outflow tract or supracuspal in the LV?
No, sir. No, sir. No, sir. We just mapped the right side only. We got success there, so we didn't map there.
Did you by chance perform any angiogram there?
Sir, I performed our RB angiography, but I couldn't show here. But I performed the RB angiography to define the level of the valve and the function of the RB or any other outpouching of ARBD or anything. But already the patient's cardiac MRI was normal, so we were not thinking anything in the right ventricle in terms of right ventricle cardiomyopathy.
Right, we could go on to the third case.
Thank you, sir.
Okay, then we continue to the presentation of Dr. Anand.
Morning, sir.
Thank you very much. Again, within the time limits, you are very fast. Highly interesting case you present. Actually, what I enjoyed in your presentation is that you added the original presentation I received. You did yet add why ifabradine has effect on atrial muscle. And I think you answered this question, which I already had in the presentation, very nicely. But let's be the advocate of the devil and ask you the following question. Could you describe for me the location of the sinus node where sinus node exits can be? So we say always that the sinus node is at the transition level of the superior caval vein.
Yes, it is an epicardial structure. It is at the transition where the SPC is going to join your right atrium. It is a posterior and superior structure.
Yeah. Let me phrase it a little bit more clear that we did some studies in the exit points of the sinus node in normal atria. And what we saw is that the sinus node has a banana-like shape. So it's not a little point, but it is going downwards along the terminal crest. And if you increase the adrenergic level, the exit point shifts more towards the AV node, which is probably physiologically very good because you shorten AV times, and in higher adrenergic levels, this is an improvement of the function of your system. So to come to my question as advocate of the devil, you think that the exit point where you mapped with the Cardo system might also be the exit point of a sinus node cells?
Actually, no, sir. Because I mean, the way you are saying is this is due to increased automaticity of sinus node, which is exiting at a different point. The way we see this is the IF current are present not only in the sinus node, they are present at multiple other areas in both the atrium. In fact, the first case of ivabradine sensitive atrial tachycardia that was described from the left atrium, which is a pretty far away structure from the sinus node. So just if we are thinking in terms of extensions, then tachycardias which are arising from LA appendage cannot be explained just by the basis of extension only. So what we are seeing is the HCN4 channels and IF currents, they are present in multiple other areas of the heart. Now we have autopsy evidence also, that is the study which I had referred to. So although HCN4 channels, they are present maximum in the SA nodal cells,
they are distributed in other areas of the right atrium as well as left atrium also probably. We do have autopsy studies on human hearts, patients from accidents who were immediately autopsied, and then immunoblot was taken for HCN4 channels, and they showed that HCN4 channels are present in AV node, AV node ring region, then right atrial appendage, right atrial free wall, which slide I have also mentioned. The only problem with the study is they did not do sections of left atrium, which was because they were predominantly studying the expressions of channels in the SA nodal cells.
Okay.
So they basically did the right atrial sections only, not the left atrium. But if there is a autopsy study which looks at left atrium also, there is a possibility that we may find HCN4 channels there also. What
So
we do have.
Sorry to interrupt you. I think your answer is completely convincing me, and the question I have additionally. So HCN4, you might see that in normal tissue, or is it always in a case of diseased tissue? Because we normally say that atrial tachycardia above the age of 40 in older patients is because of structural abnormalities. So you think, I don't know, the autopsy you did, was that in younger patients, or do you think that it's coming, it's in HCN4 you see only in diseased atrial cells?
So, sir, there are two things about the question you have asked. One is, I think HCN4 is present in normal tissue also. What happens is when it becomes disease, when the heart becomes disease, there is upregulation of this tissue. This is also evidenced by studies in heart failure population where cyclic AMP upregulates the HCN4, which forms one of the bases for reducing the sympathetic activation via cyclic AMP, as well as the use of ivabradine in these population. So that is the HCN4 upregulation in heart failure, which is a disease atrium. This study, the autopsy study which I referenced, that was done in presumably structurally normal heart, where they basically studied the SA nodal cells and then they compared it with, the immunoblot of SA nodal cells with the other cells of the right atrium. There they had found HCN4 expressions in the other areas of the heart also, apart from the SA node.
Yeah. One of the interesting slides you showed, which was not in the previous presentation yet, is that the P wave is extremely wide during atrial tachycardia, which is more than 120 milliseconds. And I had the impression that during the application of ivabradine, that the preceding termination, the P wave was even getting broader. Do you think there is additional conduction delay you get then, or is it purely the effect on the HCN4 channel?
Sir, it's probably purely effect on the HCN4 channel. If this was a re-entry atrial tachycardia, then I would have thought of, progressive delay leading to the atrial P wave widening. But because this is more of an automatic tachycardia, so that is why it's probably due to effect on HCN4 channel rather than the delay in the circuit.
One practical question I still have is that you put the patient on ivabradine and he was doing well, And then you studied him before you studied him electrophysiologically and did the ablation. How did you manage to get the tachycardias back? Did you terminate ivabradine therapy? And
Yes,
how
sir.
long did you terminate it? And what did you use to induce it during the study?
Yes, sir. So this patient, in view of presence of tachycardiomyopathy and dyspnea, according to the guidelines, 1B indication, we decided to take the patient for EP study. The relatives were counseled that they have two options: either they can continue on this thing, or they can go for a permanent cure. They agreed for ablation. Once they agreed for ablation, we stopped ivabradine for 2 days. This is because the half-life of ivabradine is 4.5 to 6 hours. So we typically stop it for 5 half-lives. So 30 hours. So instead of 1.5 days, we stopped it for 2 days. After stopping for 2 days, when the patient was taken for the study, the patient was already in tachycardia on table. So we did not have to induce.
Okay. Okay, thank you very much. Very clear answers. Dr. Naik,
the last question was the one I had, whether there was any D challenge and whether the arrhythmia was induced again. But I think we are rapidly running out of time. Nice case. Thank you.
Thank you, sir.
And we'll go on to the next cases.
Thank you, sir.
Good morning, everyone. I would like to extend my sincere thanks for giving me this opportunity to present my case in this prestigious forum. My case is, however, a straightforward diagnosis may be a bit complicated by a prior procedure. Since it's titled Mistaken Atypical AVNRT, I would like to begin with how to reach such a diagnosis of AVNRT in the EP lab. As we know, AVNRT, whether it's a typical or an atypical AVNRT, is a re-entrant circuit housed in AV node. Neither the atrium nor the ventricle are part of the circuit, and the dissociation can be shown by atrial and ventricle overdrive pacing respectively. Ventricle overdrive pacing during tachycardia will demonstrate a VAHV response with the PP I minus TCL of more than 115 millisecond. An accessory pathway can be confirmed by a hissing PVC that is affecting the subsequent A. The diagnosis of atrial tachycardia can be ruled out by the demonstration of VA linking during atrial overdrive pacing. Now that the diagnosis of AVNRT is made, an atypical AVNRT stands out by the fact that HA interval is more than 70 millisecond or the VA interval is more than 60 millisecond with an AH to HA ratio less than 1. Of note, the pattern of earliest retrograde atrial activation can have a significant overlap in both the forms and should not be used for differentiation. Although differing by electrophysiological characteristics, the management of both typical and atypical AVNRT involves slow pathway modification. AVNRT is thus a diagnosis of exclusion. Now coming to the case that I am going to present is a case of 50-year-old male with history of palpitation for the last 2 months, being referred from another center with a history of recently failed ablation attempted for atypical AVNRT. He also gave us the history of an ablation procedure 10 years back for which there are no records were available. This was the ECG during tachycardia, which revealed a regular long RP tachycardia with inverted P wave in the inferior leads, and the differential diagnosis will be an atypical AVNRT, ORT with decremental conduction, and AT with long RP. With this in mind, the patient was again taken to the EP lab with a decapolar catheter placed in the CS a quadripolar catheter, each at the HIS and the RV apex. Standard induction protocols were followed with atrial programmed extra stimulus that induced a long VA tachycardia without a AHR. The tachycardia cycle length was 320 millisecond with a VA interval of 90 millisecond, HA of 170 millisecond and AH of 130 millisecond, and an AH to HA ratio was less than 1 with concentric atrial activation sequence in CS ostium and HIS catheter. We performed the routine pacing maneuvers during tachycardia, ventricle overdrive pacing during tachycardia entering the atrial cycle length, and it shows a VAHV response with a longer PPI minus TCL of around 242 millisecond. His refracted PVC was given from RV apex that didn't affect the atrial cycle length and didn't pulled in the next A. That's suggestive of more of a right, and that rules out the paraseptal and right accessory pathway. Atrial overdrive pacing was performed, which drove the ventricle cycle length, and VA linking was demonstrated, which ruled out an atrial tachycardia. All the maneuvers pointed to a diagnosis of atypical AVNRT. However, we know for a fact that the patient had a failed attempt for AVNRT ablation recently at another center. So we took the ablation catheter to the LV, and his zinc PVC was given from the LV apex, which pulled in the subsequent A, H and V and reset the tachycardia, and thus conforming a orthodromic AVRT with the left-sided accessory pathway as the mechanism of the tachycardia. However, during tachycardia, if you see the activation is a concentric activation. To clarify the mechanism further, we took our ablation catheter to the lateral mitral annulus, which during tachycardia shown the earliest activation, even though the neighboring CS12 is showing the late activation. This suggests the presence of mitral isthmus block, which can be probably created during the 10-year-old ablation for a left lateral accessory pathway. Mitral isthmus block was further demonstrated by pacing from the ablation catheter, which showed a concentric atrial activation in the CS electrodes, suggesting the pacing stimulus had to travel all the way around the LA roof and the intralateral septum to reach the proximal and distal CS electrodes. Earliest A was mapped during tachycardia, and RF energy was delivered at 35 watt and 43 degrees Celsius, which terminated the tachycardia with local VA separation in 5 seconds. A 3D electroanatomical activation mapping was also created while pacing from the RF catheter. We demonstrate here clearly the presence of mitral isthmus block, and the electrical distance between the RF and the CS electrode was about 150 millisecond, when actually they are anatomically nearby. Post-RFA tachycardia could not be induced. Mitral isthmus block during ablation of a left lateral accessory pathway is a known entity and should always be kept in mind when dealing with such cases with past history of ablation. This can avoid unnecessary slow pathway torture and save some valuable time in ED lab. Thank you all for your patient listening.
Good morning, everyone. I am Akinchan Bharadwaj, second year DM resident at JIPMA Pondicherry, and I am here to present to you a case of young male with incessant narrow complex tachycardia. So initially, the brief history. Our patient is a 22-year-old male who presented to us with 3 months history of breathlessness on mild exertion, episodic palpitations, and fatigue. He had recovered from coronavirus disease in May 2021. He did not have any known comorbidities, and he did not have any past history of heart disease. At presentation, echocardiography showed mild global LV hypokinesia with LV ejection fraction of 40%. So this was the ECG at presentation. We have a regular narrow QRS complex tachycardia at the rate of 130 beats per minute. We can notice inverted P waves in the inferior leads. The RP interval is 280 milliseconds against the RR interval of 480 milliseconds, which shows this is a long RP tachycardia. So before presenting to us, the patient was treated elsewhere medically. He received beta blockers, digoxin, and amiodarone in that order as per his medical treatment. But the tachycardia continued to stay, it did not revert, so the patient was referred to us. We decided to take the patient up for EP study. Before the EP study, we had two questions in mind. First, what was the tachycardia? Second, what was the site of origin of the tachycardia? So the patient was taken up for the EP study. We placed the quadripolar catheters in right atrium, right ventricle, near the bundle of His, and a decapolar catheter in the coronary sinus. And this is what we came across. There's an ongoing narrow QRS complex tachycardia with long RP interval and inverted P in the inferior surface ECG. VA interval is 298 milliseconds against the tachycardia cycle length of 480 milliseconds. So we have three differentials here: atrial tachycardia, atypical AVNRT, and permanent form of junctional reciprocating tachycardia, PJRT. During our EP study, we came across this interesting phenomena a couple of times. We can see the ongoing narrow complex tachycardia. It spontaneously terminates with a P. Then we have a sinus beat which echoes back, then another sinus beat which echoes back. So after the temporary termination, the tachycardia reinitiates. So here we can observe that this tachycardia had terminated with a P. So here we can be sure that we are actually not dealing with atrial tachycardia, because atrial tachycardia is expected to end with a QRS, not with a P. Also, spontaneous termination and reinitiation is considered a peculiar feature of PJRT. So to confirm our diagnosis, we went on to do various maneuvers, and our first maneuver was ventricular overdrive pacing. So we started pacing from the right ventricular apex. The pacing cycle length was 450 milliseconds, and here we can see the AA cycle length of 450 milliseconds. So we were successfully able to entrain the atrium. Once the pacing was stopped, we have the response VAV. So here it rules out atrial tachycardia to be the cause of this patient's symptoms, because atrial tachycardia is expected to have VAAV response. But here we have VAV response. The tachycardia cycle length is 480 milliseconds, and post-pacing interval is 570 milliseconds. So we have PPI minus TCL 90 milliseconds, which is less than 115 milliseconds. So this indicates that we are actually dealing with an AVRT rather than AVNRT. So our next maneuver was a ventricular extra stimulus, which was given prematurely. We had a fusion complex, and this His refractory BBC was able to capture the atrium. So here we ruled out atypical AVNRT to be the cause, and it indicates that we are dealing with a tachycardia mediated by an accessory pathway. So this is PJRT. Our second question was, what was the site of origin of this tachycardia? So we can see the site of earliest atrial activation we have near the coronary sinus os. So this is most likely a posteroceptal pathway. So the diagnosis by EP study is slow conducting concealed posteroceptal accessory pathway, orthodromic AVRT presenting as incessant long RP tachycardia, which is also known as PJRT, permanent junctional reciprocating tachycardia. So our next step was ablation of the accessory pathway, because the patient was symptomatic and his tachycardia was medically refractory. So here we can see the placement of our ablation catheter near the coronary sinus os. So we delivered a total of 3 ablations at 30 to 40 watts at 60 degrees centigrade for a total of 140 seconds. After the ablation, the tachycardia terminated, and we have the sinus rhythm. This was the ECG taken 24 hours later after the ablation, and here we can see the patient has a heart rate of about 95 beats per minute, normal upright P waves in the inferior leads, and a narrow QRS complex. So after 6 weeks of ablation, we had this patient follow up with us. The patient had resumed his routine daily activities, his symptoms had reduced, and his echo showed an LV ejection fraction of 55%. So summarizing the case, we had a 22-year-old male coming to us with a 3-month history of mild breathlessness on mild exertion, episodic palpitations, and fatigue. His ECG initially showed a narrow, complex, regular, long RP tachycardia. We had 3 differentials in mind: PGRT, atypical AVNRT, and atrial tachycardia. We took the patient up for an EP study. During the EP study, we found that this patient had PGRT. We did the ablation of the accessory pathway, which was located in the posterior region. With that, the patient's symptoms improved and the tachycardia terminated. So the take-home points from this case is that PGRT usually occurs in infants and children, and it is quite rare to present in adults. It tends to be incessant because of the slow conducting nature of the accessory pathway, which gives it all substrate to be incessant. The spontaneous termination and reinitiation is a characteristic feature of this tachycardia, which we also came across during our EP study. The accessory pathway is most commonly located in the posterior septal region. This tachycardia often leads to tachycardia-induced cardiomyopathy, and it is potentially treatable with ablation. So that's all I have. Thank you very much for your attention.
Good morning, everyone. My name is Suresh Kumar. I am senior resident in Department of Cardiology, Sri Chitra Tirunal Institute for Medical Sciences and Technology, Trivandrum. Before going to my case, I would like to thank organizers for giving me an opportunity to present this prestigious platform. My case is an interesting case of pure tachycardia in a patient with WPW syndrome. Going to the patient, who is a 52-year-old lady with structurally normal heart presented with recurrent episodes of paroxysmal palpitation. This was her baseline quality ECG, which showed manifest pre-excitation suggestive of right-sided axillary pathway. After taking informed consent, the patient was taken up for electrophysiological study. We placed a diagnostic quadripolar catheter in his fundal region and right ventricle, and a decapolar catheter was placed in the coronary sinus with CS1-2 dipoles in the distal coronary sinus region and CS19 dipoles in the proximal coronary sinus region. We also placed a mapping ablation catheter in the right atrium. This was a baseline intracardiac electrode, which was showing narrow QRS with sinus cycle length of 520 milliseconds, with age interval of 64 milliseconds, with a short HV interval with baseline pre-excitation, showing negative delta wave in lead V1 with early transition, and also negative delta in lead 2, 3, and area such to right posterior axillary pathway. Then we proceeded with the retrograde study, which showed concentric retrograde atrial activation with earliest in CS proximal region recorded in CS19 dipoles, and it is also a non-decremental conduction across the axillary pathway with axillary pathway retrograde effective refractory period of 250 milliseconds. Coming to the anterograde study demonstrated effective refractory period of axillary pathway 220 milliseconds. Upon atrial pacing, tachycardia got induced easily, and this tachycardia was a wide complex tachycardia with right multi-branch block morphology, with earliest A in CS proximal region recorded in CS19 dipoles. And the tachycardia cycle length was 274 milliseconds, and the mechanism of tachycardia demonstrated was orthodromic AV re-entrant tachycardia, as demonstrated by this refractory PVC, which advanced A. Then we went on with mapping around the tricuspid annular region during the tachycardia, which showed earliest A at 6 o'clock position of the tricuspid annulus. Then we went on with radio frequency ablation at the 6 o'clock position of the tricuspid annulus. Within 2 seconds of initiation of the radio frequency ablation, tachycardia was converted into the tachycardia 2. This tachycardia 2 was around tachycardia cycle length of 350 milliseconds. It is also a right bundle branch morphology tachycardia with earliest A at CS proximal region. Again, the mechanism of second tachycardia was confirmed to be orthotomic AV pre-entrant tachycardia based on his refractory PVC, which advanced A. Then we went on mapping the tricuspid annular region during the tachycardia. At 8 o'clock position, we recorded earliest A. Then we went on with RF ablation at 8 o'clock position of the tricuspid annular. Within 6 seconds, the tachycardia got terminated along with loss of pre-excitation. This was the ECG post radio frequency ablation of both the tachycardia, which showed there is loss of pre-excitation. Post radio frequency ablation, we demonstrated there is no anterograde or retrograde conduction through the axillary pathway. So this case demonstrated a dual loop tachycardia associated with WPW syndrome involving two pathways on the right side, which are right posteroseptal and right posterolateral axillary pathways, which were successfully ablated. Thank you.
Hello, nice cases, and maybe I'll just go on with a few questions quickly, and Professor Smeets can supplement those questions. Regarding the first one, mistaken atypical AV NRT. Praise, a couple of questions. When you were doing his refractory PVC, writing the beginning of the study, were you giving the PVCs at the paraseptal region, it was in the RVOT region, or it was in the RV apical region? Because you showed, I think there was no advancement of A when you were giving his PVCs from the right side. Yeah, you are muted, please.
So it was from the RV apex. It did not advance the A.
Yeah, so was any attempt made to do it from the RVOT region? It's a little easier to penetrate and maybe make some changes. RV apex is too far away, especially in AVN-RT, to make any kind of change.
No, sir, it was not tried.
And during any LV pacing during the study, was there gross change in the atrial activation pattern compared to that during tachycardia when you were doing LV pacing? In the atrial activation pattern when you were doing LV pacing versus during tachycardia, was there a local atrial activation pattern changing?
So when we paced from LV apex, it was a concentric activation there.
So did you pace then from the LV lateral wall region to get local activation to change, or?
Yes.
Sorry, sir?
So were you pacing from the LV lateral wall region when you diagnose the concealed pathway with the mitral block?
So we paced from the LV apex, sir. Then we did from.
Okay. Professor Smeets, mitral annular block, of course, it's a very interesting phenomenon. We need to be aware of it whenever a patient has previous ablation, or even during first ablation when you see a sudden change in activation pattern. Professor Smeets, any comments to that?
Maybe one remark and also a comment and a little question. You mentioned that there were several ablations before the patient came to your lab, and the ablations do you have any idea where the ablations were done, especially in the right posteroceptal area, but also within the coronary sinus? You have any clue of that in the description?
So we don't have the history of the old ablation, which was done 10 years before.
Yes. If you mapped the right side and also the coronary sinus, did you see in the local electrograms fractionation, or were this nicely delineated spikes of a normal atrium?
I'm not sure about that, sir.
Okay. Because if you see many ablations have been done, this might lead to a destruction and cause this block, what you suggested. And one of the things which struck me, my eye is that if you look to the surface ECG, the RP was actually shorter than the PR interval. So that is always suggestive for an accessory pathway, if especially the AV nodal is excluded. Okay, these were, I think, the additional questions I had for you. Thank you.
Okay, thank you, sir.
Thank you, Prof. Smeets. So technically, it was not a long RP tachycardia. The RP was a little shorter than the PR.
Yeah.
But yes, nice case. The next case, Akinchan, regarding incessant SVT post-COVID patient, PGRT. Couple of questions. During the initial study with the RV program stimulation, the retrograde conduction, was it decremental or how was it? Non-decremental or decremental? Akinchan, are you there? I don't see him on the screen. So should we go to the next case, Amir? Next case of dual loop tachycardia, WPW syndrome from Sri Chitra. Question was, the tachycardia was RBBB morphology. Was there any underlying Epstein's anomaly or Epsteinoid anomaly which was considered?
No, sir. No, sir.
I'm losing the audio.
Detailed evaluation, and it was structurally normal.
It was a structurally normal heart, you said, right?
Yes, sir. Yes, sir.
Yeah. Interestingly, your pathways you localized to like 6 o'clock and 8 o'clock.
8 o'clock.
Was there any chance, did you attempt to put a multipolar catheter across the tricuspid annulus, which could have mapped these better and the transition would have been better seen? Was any attempt to do that?
No, sir. No, sir. No.
Okay. When you say dual loop tachycardia, the connotations are slightly different, and we talk about it in a little different context. So in essence, what you're basically saying is there are two pathways, and the orthodromic AVRT was going around one, and when you ablated, it started going up around the other. Is that what you're saying? Because when we talk about dual loop tachycardia, we talk more in terms of reentrant tachycardias and IHRTs, and the connotation is slightly different. Actually, I'm losing the audio and Amey, are you able to hear? Because I am not able to hear. Maybe it's an audio issue on my side.
Maybe in the meantime, it's good if you have double accessory pathways. One of the, we described a case in 92 in a patient who had 3 accessory pathways. And one of the ways you can unmask accessory pathways if they are conducting in antegrade direction is by incremental atrial pacing, because pathways sometimes have a different antegrade refractory period. And if the refractive period is different, then at different pacing rates, you see the different patterns of pre-excitation. And if I remember correctly, in the Kumar paper, there was also an ECG with atrial pacing where we saw 2 types of pre-excitation. So incremental atrial pacing might give you the clue whether there's more than one accessory pathway. I see that Dr. Bardwa is back. Can we switch to the second presentation, comments to that?
Yeah, sure. Akinchan, are you back?
Yes, sir. I'm here, sir.
Oh,
Am I
okay.
audible, sir?
Good. Yeah, now you're audible. We lost you in between.
Yes, sir.
So your case was interesting, PJRT. PJRT in a patient, in a post-COVID patient with incessant ST, isn't it?
Yes, sir.
Yeah. You know, PJRTs are also common in the adolescents and young adults, and we do see tachycardiomyopathies, especially in the ladies, in females, and not that rare. Couple of questions was, during the initial EP study, when you were doing the programmed stimulation from the RV, was the retrograde conduction decremental or non-decremental?
It was decremental, sir.
Okay, and with his refractory PVCs, you were getting advancement of A during the tachycardia? Because
Sorry, sir?
PJRT is in PJRTs, we can have both response. With programs, with his refractory PVCs, you may either get advancement of A, or you may also get retrograde decremental conduction via the pathway. So the VA can actually be longer. So what kind of response were you getting with his refractory PVC? Was there advancement of A or further delay in the VA interval?
I'm not exactly sure, sir. We had VA interval of 298 milliseconds. So cycle length was 480.
So with his refractory PVCs, were you able to advance the A, or there
Yes,
was
we were able
further
to-
decrement in the A? Because both responses may be seen in PJRTs.
We were able to enter in A, sir.
You were able to advance the A. The VA
Yes, sir.
became okay. Right. Professor Smith, any questions there? Any comments?
Yeah, I have some questions, two questions actually. One is about the presentation of patients with PGRT. In my experience, very often it's the dyspnea, which is the most common complaint. I saw in your presentation that you also complained of palpitations. Do you have any idea at what point in time he feels palpitations?
So basically his main complaint, which was always present, was dyspnea, and it was gradually progressing. Initially he was having on exertion, and gradually on mild exertion, on routine daily activities it was there. Palpitations, he said it was always exertional palpitations.
Okay. Did you have opportunity to look at what happens if the autonomic status of the patient is changing with the tachycardia cycle length? So to make it more precise, did you see at night a lower heart rate of the tachycardia during sleep than in daytime? And did you see a higher rate during exercise of the patients in daytime?
No, sir. He almost always had a rate around 120 to 130 in between.
So
even while asleep.
You think that the autonomic influence in these patients was not very evident?
Not much. Yes.
Okay. Okay. Thank you very much.
Thank you, sir.
Thank you, Professor Smeets. Thank you, all the presenters, for good cases.
I request I request both the judges to WhatsApp the scores to
Sure.
Dr. Ashish.
I'll
WhatsApp.
do that.
Yeah. Thanks a lot. Yeah.
Thank you very much. I hope we've not exceeded the time.
No, not at all. Because I think here break is almost like 1.5 hours.
Oh.
So it's good. Thank you.
Thank
Bye.
you very much. Thank you.
Bye. Bye.
Thank you, sir.